My name is Emma Rahmawati. As Dr. Chatter said, that I'm a lecturer at University of Muhammadiyah, Professor Dr. Hampa, Public Health Department. This research is also with my colleague, Didi Kusumawati and Sutoto. Sutoto is from, he is a medical doctor, and also Dini Kusumawati is from the Ministry of Health of Indonesia. So my research, I will present the findings of our research on an analysis of the application of vigilance or undesirable occurrence reporting on a health e-watch medical equipment for business operators in Indonesia. Next slide. Actually, this is the background that medical devices are essential in diagnosis, monitoring, and also treatment. So yeah, they may cause adverse events, or we said that Indonesia is KTD, kejadian yang tak diingat. It means that yeah, like adverse events alongside the therapeutic benefits. Vigilance system is crucial to manage, and also for how reporting is adverse events. So adverse event reporting helps improve product quality and also patient safety. In Indonesia, we use e-watch ALKES. ALKES is medical devices as an electronic adverse event reporting system. So this is not long ago. So it is also already socialized, already implementation in Indonesia. So next time, yeah. So what the problem in Indonesia about this reporting adverse event that sorry, in 2023 only 7 manufacturers or distributors reported adverse events through the e-watch medical equipment or medical devices system, with just only 36 total reports. I don't know, is it good or bad? Because just a little bit, reports there, but unfortunately, that the reports, most of the adverse event reports came from healthcare providers, not from the device companies themselves. So this is the problem. So this is our highlight in our research. So our research objectives is to identify the profile of the business of the medical devices business, or the demographic, knowledge, and attitude factors that we will prove is it influence of the AE reporting practices. And also to assess the compliance level of medical device in business in reporting AEs in Indonesia. The third one, to analyze the relationship between demographic factors, knowledge, and also the variables with the reporting compliance, and also with also the qualitative approach. It is to explore supporting and hindering factor in adverse event reporting among medical device businesses. So based on the study that most medical devices are designed to be safe and effective, but AE can still, or adverse event can still use. These even are often multifactorial, so involving human error, technological design, like also for other factors, and inadequate supporting infrastructure like maintenance, utilities, procurement. So understanding the complex causes of AES requires a system-based approach. Sorry. Yeah. So vigilance, what is vigilance? Vigilance is about malfunction or deterioration in characteristic or performance of the misuse of a medical device that may causes or contributes to death or serious injury of a patient or other individuals. the objective is to enhance the protection of patient, users, and others by disseminating information that can reduce similar incidents or prevent the recurrence of adverse event or like near misses or something like that. So in Indonesia, we have a e-watch medical equipment. This is an alert system that provides open information on medical devices that may pose risks to patients, healthcare workers, or the public, and is easily accessible to the general public. So um, there are four key factors involved in the safe use of medical devices are accessories, operators, patients, and also the infrastructure. So where care is provided, failure or operational issues in any these factors or their interaction can lead to adverse event. And it's so this is my our framework of our research. Uh, so we did a mixed method to do the research. For the quantitative method, we measure the compliance level or medical devices business operators in conducting vigilance. It's called vigilance for the reporting adverse event in medical equipment in Indonesia through the e-watch system using a cross-sectional design with a questionnaire. And for the qualitative approach, we try to obtain a comprehensive overview of adverse event report practices by medical device business operators through structured interviews and also focus group discussion or FGD. So the sample, we have here 178 respondents in Indonesia selected using simple random sampling. For your information, in Indonesia there are 1,258 medical device business operators, including 462 of manufacturers and 797 distributors. So we did analysis by univariate, chi-square for bivariate, and logistic regression. And as I said before, for the quality analysis, we did a in-depth interview and also FGD. Sorry. So for the qualitative, we have three kind of informant: key informant and main informants and supporting informants to do the in-depth interview and also for FGD. Of course, there are all the informants are included in the issues of this. So as I said, it's too small, right? The, the sentence, yeah, okay, the words. So we have this most respondent where this is the characteristic or the profile of the respondents. So mostly from the age from 20 until 30 years, and also the majority were female. And respondent also in the position of technical responsible person, and also had a health-related educational background from pharmacy or medicine, and also have most of them had more than 3 years of experience in the health sector. So this is the profile of the respondent. I mean the company of the medical devices, the status, also the certificate of most of them is is from government, sorry, and also has also had a certificate and established more than 5 years. So this is the area. The area the area of the company of the business is in Jakarta and around of the Jakarta. So this is the first research in Indonesia, I think. So okay, next slide. So the result of the quantitative study, we see that first the attitude of the respondent, about 40 still, yeah, it's not so good because the positive attitude only 92%, or same with the yeah, half of them. So 51.70 0.7%. So this is the attitude and the knowledge. How about the knowledge? The knowledge, I think, among licensed medical device business operator, uh, there are 53.4 had a high level of knowledge regarding AE reporting regulation. We asked about that, and also the only 7.3% who had a very low knowledge level. So how about the compliance level of the adherence to adverse event reporting practices? So among licensed medical device business operators across Indonesia, there were 127 respondents, or almost about 71.3% demonstrated a compliant level of adherence to adverse event reporting practices. So how about the significance or correlation of between the variables? So the first one, that how about the compliant? With the compliant, we can see business operator profiles such as ownership and on status, business type, certification, years of operation, and possession of a technical responsible person certificates showed no significant association with compliance level. We the measure is based on the p-value. Is all the p-value are more than 0.05. So how about the knowledge versus compliance? Yeah, about the association, no significant association with compliance level. And for the attitude, we can see here that attitude shows a significant association with compliance in adverse event reporting. So respondent with a positive attitude were 1.8 times more likely to be compliant compared to those who have a low attitude. It is prevalence ratio because we do the cross-sectional study. So how about the analysis for multivariate? We use regression logistic. It showed that attitude was the most significant factor influencing compliance among licensed medical device business operation in adverse event reporting. So this is indicated by p-value, which is significant, and also the highest odds ratio, which is 2.24 among the variables, all the variables observed. Let me, I don't know, yeah. This is the result qualitative. We do some theme to discuss in FGD and also in review. We see that about the understanding about vigilance, most of I think like the quantitative result have a good level of knowledge about this, and also a good understanding. So how about the reporting process? So the vigilance reporting process in medical device companies is generally incidental with reports submitted. Just only when they have incident, they reported, not continuously. So the other theme is about the duration of vigilance system implementation. So Yeah. So the duration of vigilance system um, in implements medical system, companies range from less than 1 year to 4 years. So this is reflects that. Sorry, it is reflects. Yeah, this is reflect. Yeah, this is a product. Yeah, this is a reflect. Sorry, I have to. This reflects that most companies are still in the early stages of implementation, with only a few having adopted the system uh, in a more sustained manner. So, however, the investigation process for the AE, it was even so the action taken by companies in response to the AEs involve investigation processes with users, distributors, and sales representatives before reporting the incident and to the Ministry of Health. So the other qualitative research are okay. It's okay. So this is also a discussion about this, but I will share this presentation. You can read it because it's so many words to say because the compliance of medical device business affect the implementation of vigilance. So according to research, the other research vigilance report are very important, yeah, very important things, and also it can boost sales. So the compliance level of this with distribution permits across Indonesia shows a positive trend. Now it becomes better. So most of the company comply with the regulation, though some remain non-compliant, indicating room for improvement. So this is a very mm, not so long. Yeah, it's a new one, especially to shift the non-compliant groups to compliant. So compliance of medical device businesses affect the implementation of vigilance. According to research, also it is the same words. Sorry. The vigilance system involves not only understanding concept about the vigilance of course, but also complex processes. So including multi-level reporting flows from consumers to through distributors to companies and to the Ministry of Health. So this complexity and multiple stakeholder involvement explain why good knowledge does not always directly correlate with reporting compliance. Vigilance systems involve not only understanding concept but also complex processes like I said before, including multi-level like reporting flows from consumers through distributors and to companies and also to the Ministry of Health. This complexity and multiple stakeholder involvement explain why good knowledge doesn't always directly correlate with the reporting compliance. Next. So this is the conclusion of our research. First one is the majority of medical device of business is about 71.3% are classified as compliant, um, indicating that most have effectively uh, involved and accordance with the regulatory requirements. So the second one is the level of knowledge among medical device businesses regarding vigilance regulation in Indonesia shows that nearly half of the respondents, or about 46.6%, need improved in understanding of these regulatory requirements. The third one is the attitude of medical device business toward implementing vigilance in Indonesia indicates that significant proportion of respondents, it's about 48.3%, and still hold negative attitudes uh, uh, toward AA implementation. The fourth point is the analysis of factors influencing vigilance compliance in Indonesia shows that compliance is not effective by business profile. Like research so, yeah, there's no significant relationship or knowledge also, our knowledge level, but attitude has a significant relationship uh, with the level of compliance. So, from the qualitative side, adverse event reporting by medical device businesses has a significant impact in quality assurance in Indonesia and plays a strategic role, yeah, in evaluating the quality of the products on the market. So, okay, recommendation for the government as a regulator, it is important to improve the accessibility of the e-watch algorithms or medical devices to also the following user guidelines for medical device business. Probably the guidelines should be familiar or should be more socialized to the medical device businesses. For the medical device businesses, we recommended to be more active, to be more active, especially in their participation in training, and also for the outreach program from the Ministry of Health to enhance implementing of a adverse event reporting regulation. So for the further research, if there's someone else to do the same research, I hope that it will be expand the scope of representative respondents by integrating variables such as organizational culture and also local policies in the implementation of the vigilance system. For your information, my research mostly my research is about patient safety, and we we heard that uh, Indonesian culture and also for leadership. I think for leadership is very important to make this happen, also especially in compliance.
Assalamualaikum and good day everyone. So I'm Fazila from University Putra Malaysia. So I'm just going to share the findings of our recent research projects on sexual risk behaviour among university students in Malaysia.
Yeah.
Okay, so a bit on the introductions. Well, sexual risk behaviour, or we acronym said as SRB, is a major public health concerns not only in Malaysia but I'm supposed in the worldwide. So it's to define what is SRB, it is a high risk acts which includes premarital sex, unprotected sex, and also multiple partners. And as according to the CDC definitions, it's a behavior that places a person at increased risk of sexual transmitted infections such as HIV, and also other social issues such as unintended pregnancy, having multiple sexual partner, and also starting sexual activity at a very early age, I suppose. In looking at the prevalence of SRB worldwide as a global trend, especially in looking into the low and mid-income countries, the prevalence reported was 16.2% of adolescents has engaged in the sexual activity. But specifically in Southeast Asia, generally it's 2.5%. And one of the study in Southeast Asia looked into this matter. It reported that the highest was 26.4% in Timor-Leste, and the lowest was in Indonesia, 5.3%. As per our populations in Malaysia, the amount actually tripled the amount almost triple the amount from the Southeast Asia general, the 2.5%, but in Malaysia it was reported by our national survey in 2017, it was 7.3%, and it's even higher among the university students as reported by Folasayo et al. 2017 as 20%. So examples of sexual risk behavior, like I said, unprotected sex, multiple sexual partners, with partners with high risk behavior, sex under the influence of the drugs, early initiation of sexual activity, and also inconsistent or incorrect use of the contraceptions. And why is it matters? And why we look into this matter was because these behaviors are associated with many issues, such as higher rates of STIs that impairs sexual and reproductive health of that individuals, and also socially it increases the likelihood of unintended pregnancies and leads to illegal abortion and also baby dumping, and also in terms of psychosocial consequences it leads to a lot of stigma, regret, and also mental health issues. So in this study, we cover the university students. Why was the university students? Because this group of population often gets overlooked, as they are deemed to the health as the healthiest population. So not many study that look into that focus into this age group. Most of the studies that we have made some background check was more on the adolescence group. So youth is actually the combinations of the age in the youth is between 18 to 25. So a bit of adolescent group plus young adults group. So looking at these groups, there are many factors that have shown to predispose to sexual risk. And this we group it as into three aspects, which is the self aspects, family aspect, and also the peer factor aspect. Okay, so in this study, it's a nationwide research study. So it has not been done in Malaysia as a nationwide study.
Media,
Right?
oke ya. Kalau kamu nggak selesai sekarang, udah tahu ya konsekuensinya ya.
Um,
Ya, ya. Ini agak spesial juga.
Okay, so the objective of my study is there are four specific objectives. First, that we look into the social demographic characteristics, okay, and then secondly, we look into the multi-system factors, specifically the self, family, and peer. So we covered all three, and then number three objective was to look into the prevalence among the university students, and four, to determine the factors and also to look into the predictors associated with the sexual risk behavior among the university students in Malaysia. So this is our conceptual framework. So we look into social demographic, self systems, family systems, and also peer influence, peer systems. So all these we want to look into their relationship towards the sexual risk behavior. So, in terms of methodology, it's a cross-sectional study, and the study setting was in the local higher education institutions, and the study population was students, aged from 18 to 25, who are active during the data collection periods, and the data collection was about 7 months durations. And this study already got approval by our ethics committee, and also this study was funded by the government Ministry of Higher Education of Malaysia. Okay, so in terms of the data samplings, it's actually a two-stage sampling, which applied at the university levels and also at students level. So Malaysia is actually divided into, as you can see the map here, Malaysia is was divided into six regions. Five was in Peninsular Malaysia and one from the Southeast Asia, East Asia, sorry. And then institutions were then selected by using statistic random generator, and the students of the selected institutions then were selected using the convenience sampling. Okay, so sample size calculated minimum required was 442, but we got more, alhamdulillah. So this is the data collection. So how we collected it, we approached 1,206 students using the convenience sampling at university levels. And then a link was, it's an online survey. So a link was given to them to look for eligibility. So out of that, 25 not fulfilling the eligibility was excluded. And then those that are eligible were given informed consent, and then a link to the questionnaire, and all the questionnaire written were checked for completeness, and two were incomplete and was excluded. So in total we received 1,171 respondents. So this was the study instruments that we use. It's a self-administered or online questionnaire. So there are 5 sections. So the first one was socio-demographic and academic backgrounds. Number 2, it's more of a self systems, which we covered the adverse childhood experience, religiosity, knowledge on sexuality, and also attitudes towards premarital sex. The number 3 components was for the family. So we look into 2 things. One is the parent marital status, and the second one was the parenting style, using the parental bonding instruments. Number 4 was the peer pressure scale. And the last one was the dependent variable, which is the sexual risk behavior. So looking at the result here, the mean age of the students, the respondents was 20, and mostly male, and higher, mostly are males, mostly were Malays and Muslims, and looking at here, most of them are living with the family. I think it's because of the data was collected during the COVID-19 time, so they were quarantined. And then most of them are, almost all were single, and the parental status married was 84, and then mostly were in the lower socioeconomic status. Fair institutions between public and private institutions, and then most of them were social science students. And on the right side of the slides is the multi-system factors associated with the sexual behavior. So all these are analyzed as a continuous variable. So these are the means and also the standard deviations of those variables. So looking in focus to the sexual risk behavior among the Malaysian youth, okay, from here we can see that the prevalence of sexual risk behavior among these Malaysian youth, Malaysian students, was 7.2%. Okay, not much, not many, I mean. Okay, and looking into the specific items, most of about 9.5% had uh, were were having sex, the first sex, in less than when they were less than 16 years old, and then 35.7% admitted that they have more than one partner. Okay, and 28.6% did not actually use protected did not have protected sex, and then 13.1% admitted that they ever had sex with the high risk sexual partners. So this the items, all the 4 items below were a bit alarming for us in Malaysia, looking at from because we are Muslim country, so it's a bit alarming for us. Okay, so for simple logistic regressions to look into factors associated with sexual risk behavior, so age was found to be significantly associated. Other than that, race, religions, living with also, and then types of institutions, substance abuse, adverse childhood experience, religiosity, attitude towards premarital sex, mother care, and also father care, and also peer pressure were found to be significantly associated with the sexual risk behavior. So from all these factors, from significant factors from the simple logistic regressions, we put it uh, into the multiple regressions, which I will explain later. I will show later. So a bit discussions on the sexual risk behavior. So overall prevalence of sexual risk behavior among university students was 7.2%, which is lower than the prevalence obtained from other local studies such as Olasayo, which shows 20%. Also, Nifarid et al. 2013 also showed quite high, 62.3%. But these inconsistent results probably was due to um, the population, the different populations among between our study and both studies. Okay, because for Nick Farid et al., the studies was conducted in welfare institutions where all the single parents, single mother were sheltered at the institutions. And one third, about 35.7% of respondents claims to have multiple sexual partner, which seems to be higher compared to previous study. Okay. Um, so looking at the Yi et al. 2018, although using the similar populations, but the study questions only focus on the sexual behavior for the past 12 months, whereas in our study, the respondents were asked within their lifetime, sorry. So probably because of the different durations that may produce a different results. And also sensitive questions could have been a barrier during sampling, as this was collected at school for Yi et al. Um, Hence, honesty could be questions during the data collections. And another findings was more than two-thirds, 71.4% of the students engaged with sexual risk behavior reported to have protected sex. Okay, this amount is significantly higher compared to the national survey, reporting only 12.7% practicing safe sex. But our national survey was done among the adolescents, but this study was done among the university students. So the populations differ. So that's probably the reason for it. I couldn't find any survey among the university students in Malaysia as a whole that involved the nationwide. Only the one that was done before was only those focusing on one institutions or maybe one regions of Malaysia. So it was not nationwide. Okay, this was what I was talking about. So those from the simple logistic regressions, those factors, those variables who are statistically significant were put into the multiple logistic regressions to look into to find out the predictors of the SRP. So from here we can see that age. The older age group had a higher tendency to engage with SRB, which is 1.88 times higher as compared to the younger group. So this could be because the older group tends to have higher sexual desire and functions compared to their counterparts. And this study also found that majority of the participants in the older age group reported to practice protected sex, which is possibly due to having more awareness on the preventions of sexual transmitted disease and unwanted pregnancy. So, however, a lot more studies, local settings, many studies did not show significant associations between age and group. Like I said, probably the inconsistent, probably due to the different respondent coverage. The second one, second predictors is the smoking history. So in this study, cigarette smoking itself shows 5.9 times higher associated with higher risk behavior. So which is similar to other study before this. Um, and similarly to alcohol also, those taking alcohol has 1.93 raise of 1.93 times higher to engage with the sexual risk behavior as compared to those who does not consume alcohol. Right. And these two, smoking and also alcohol intake, it's more of the human behavior. So it could be the result may be influenced by the external factors per se. Okay. And for religiosity, the type of religiosity, non-organized religious activity. So for in our study engagements in this type of religious activity, um, for at least 2 or more times per week was found to be a protective predictor of SRP, which is similar found in other studies by Francis et al. And Pelzer et al. Um, and father care, this one, to our surprise, it's not mother that shows predictor, but it's the father that was found to be protective of SRB, which signifies the importance of a father role in SRB of the young adults. But this is also consistent with other study actually. Uh, and the last one is the peer pressure. So another discovered major predictor of SRP, which also similar results are found among Malaysian youth, as reported by Muhammad et al. 2017. So close friend sexual behavior has a significant impact on individual perceptions and perceptions towards peers' sexual conduct, and also sexual experiences are positively correlated. Okay, so this can be due to people in sexual relationships selecting friends who share their beliefs and values, or it might be because of the peer pressure of friends' motivations. So that was the result. So the strength of this study, it's a generalizability of the study because it covers the whole Malaysian. So the whole Malaysia, and this is the first study that cover nationwide and focusing only on the youth populations in Malaysia. So, and the other strength is that we look into all three factors: self, family, and also peer. The only limitation that we encounter is the study was done during COVID-19, so a lot of factors might be affected, such as their mental states, and also applying in terms of collecting the data also was a bit difficult for us. So and also we need to conduct it on as an online study, so a lot of understanding and clarifications was not being able to be conducted. So unsure whether the respondents answered the questionnaire in a proper manner or not. So as a conclusion, the prevalence of sexual risk behavior among the uni students was 7.2%, and age, smoking or vaping history, alcohol use, non-organized religiosity activity, father care, peer pressure were found to be significantly associated with SRB, and these factors should be explored further and made relevant into strategies on preventions of SRB. And strategies should also be made parallel to the need of the local youth, as this generation represents the future of our country. So these are my references. Thank you. That's all for me.
Okay. I would like to thank Syntax Conferences for giving me the opportunity to present my talk in third international webinar on primary care and public health. Myself, Dr. Manik Chandra Tiwari from Tata Memorial Center, ACTREC, Navi Mumbai, India. I would like to talk on quality evaluation of sample collection facilities. Yeah, sample collection facilities of accredited and non-accredited medical laboratories in various states of India. So basically, I am going to talk about medical labs. Now, a small introduction to a medical lab. A medical lab is a place where tests are conducted on patient samples. Information on patient health is obtained, which helps in diagnosis, treatment, and prevention of the disease. So, medical laboratories are categorized as hospital-based laboratory, corporate laboratory, standalone laboratory. Now, this is a very important diagram. Here you can see in the circle, this is the pre-examination stage of medical practice, where the patient goes to the doctor with his signs and symptoms and is not well. The doctor sees, and suppose he wants to diagnose the patient based on certain evidences, then he will write some tests, and the tests are to be conducted in the lab. The patient will definitely go to the collection center, sample collection facility of the lab, and get the sample collected. The sample may be transported, and the sample reaches the examination station, where the sample is examined, and the reports are produced in the post-examination phases, and the report reaches to the doctor, and the doctor reads the report, interprets the report, and based on the clinical correlation, he will treat the patient accordingly. So thus, the medical laboratory stages are divided into pre-examination, examination, and post-examination. So this brief introduction, I would like to proceed further now. Errors in the medical laboratory. Why I have done this study? This is a very small short-term study. So this study has been done because the literature says in pre-examination stage, there are 70% of errors associated with total medical laboratory errors. And within the 75% of total medical laboratory errors, 26% may be very detrimental. They might be having risk to the patient. The patient may die also. The patient may lead with unnecessary investigations or inappropriate treatment, and which increases the length of stay in the hospital and very dissatisfaction among the healthcare services. So about the study, I would like to brief the study, how I have done the study. This is a question-based study where 50 medical laboratories were selected from different states of India. And these medical laboratories were termed as RLML because they were Resource Limited Medical Laboratories. Now, among these 50 medical laboratories, seven were accredited. In India, we have got a national board, which is called as NABL, which gives accreditation to medical laboratory based on international standards. That is ISO 15189, the current one is 2022. 143 medical laboratories were non-accredited medical laboratories. A questionnaire was prepared based on an NABL 112 document, which is a document checklist basically for sample collection facilities. So 51 questions this checklist have. So this 51 question checklist was taken to all the labs, single lab, and the data was collected. So this is the distribution in India from where the data was collected. From the north zone, from 10 labs, 35 is there, from the west zone, from the east zone, 2 labs, and from the south zone, 3 labs were selected, and the data was collected and gathered based on these 51 questions. Now, this is NABL 112, which is a specific criteria for accreditation of medical laboratories. This is NABL published document, that is the National Accreditation Board for Testing and Calibration Laboratory document, NABL 112, and this is the checklist, basically a 51 questions checklist. You can see there are 51 questions, different types of questions are there, based on which we can evaluate the quality performance of the sample collection facility, whether they are working properly or not. Now, about the study responses, the data collection and management, total 50 labs and 51 questions, so 2550 data was collected. It was fed on the Excel spreadsheet, and the scoring criteria was like, it was given score 1 was given if the compliance was met, if the labs are meeting the compliance, if the question which was the checklist giving If it was in compliance, then 1 score was given, and if it was not in compliance, then the score was 0. Now the calculation was basically done. The number of compliance, the percentage of compliance, both the accredited and non-accredited labs were meeting for certain criteria among the 51 questions. So to make the study more robust, since it was between two groups, the statistical evaluation was done using chi-square testing, where significant value for P was kept 0.005. When the interpretation of the finding was done, like when the SCF, that is sample collection facility checklist, met the criteria, P was less than 0.005. It means the lab needs to enhance practice by adding to the checklist. Now, this is the questionnaire based on premises, provision for privacy during collection. Now, this provision for privacy during collection, you can see in the first column, accredited labs, 7 were there. So all the 7 are meeting this criteria, that they were providing privacy to the patient. You can see the figure. In between patient also there are curtains. So privacy to patient was there, given in the accredited, but it's non-accredited. 35% only labs are meeting the criteria. So this was a finding. Hours of operations should be displayed on the sample collection facility, because based on the hours of operation, the patient gets an idea when the patient has to come to the lab, visit the lab of sample collection. So in the accredited zone, you can again see 100% accredited labs are meeting, whereas 40% non-accredited labs are meeting. Now, non-significant findings were seen in certain questions, like size of the premises. Almost the labs are meeting, all the 50 labs are meeting the criteria of the size, and the workload was met properly, and reception area and collection area was separate from the waiting area. Then hand washing facility was there, and access to hygienically maintained toilet facility was also maintained. These two criteria were not assessed because of maybe practical difficulties. Then other questions like whether the humidity and temperature was suitable in the sample collection facility, whether cleaning policies were available or not, was it ventilated properly and prevented from dust. So these are the significant findings, and you can see all the accredited labs are meeting the requirements, but non-accredited only a few 33%, 5%, and 40% are meeting. In the non-significant finding, you see all the labs, most of the labs among the non-accredited zone was also having a good, adequately light and clean facility, and housekeeping was adequate. Then you can see here in this criteria where the refrigerator temperature has to be recorded properly for checking the performance of the refrigeration. You can see here accredited labs were meeting the criteria for this refrigeration temperature monitoring requirement, using a calibrated thermometer, proper storage of supplies and consumables, and basic first aid material are kept in the sample collection facility. Power backup for equipment, 71% of the accredited labs meet the criteria. Non-accredited lab again only 5.55% meeting this criteria, and this was a significant finding. Then few findings were good in non-accredited labs also, because their compliance, 56% were meeting the chair requirement for sample collection, and almost 100% were having a good communication, telephone communication devices kept in the sample collection facility. These two criteria was not assessed because of practical difficulties. Then again, coming to the other findings, which were you can see your materials required. You can see almost all the labs were having the materials which are required for sample collection, like evacuated tube collection, syringes and swabs, etc. Non-expired materials or supplies were not much, even in the non-accredited labs. Now you can see here the training records. The training records for non-accredited labs, finding is very significant. 0%. None of the lab in the non-accredited zone were meeting the criteria of training. They didn't have any training records in the sample collection facility. But as far as knowledge of first aid is concerned, only 23% of the non-accredited labs are meeting the criteria how to do first aid to the patient or to the staff. Suppose there was a needle stick injury, or suppose the staff was fainting, or the patient was fainting due to maybe vasovagal or because of doing the sample collection. So this was a significant finding. Then manpower, as far as workload is concerned, almost all the labs are meeting, even in the non-accredited zone, you can see 86% labs are meeting the criteria. Now, I would like to just show a requisition form, which should be as per the ISO international standard requirement. When the patient comes to the doctor, there should be a proper requisition form. The requisition form must contain the demography from where the patient is coming, the patient's detail like name, age, sex, and the doctor's detail like the name of the doctor, from the destination of the doctor and contact details. And then sample, whatever is collected, whatever the sample type has to be done properly, whether it's blood, fluids, sputum, the stool, microbiological specimens, slide tissue, whatever it is. Date and time of primary sample collection has to be mentioned. This is very important because this helps in processing the sample within the stipulated sample. When the sample doesn't lose its integrity, and the sample can be processed before the time, and also it helps in the tag calculation of turnaround time. Date and time of receiving the sample in the lab, that also should be kept as a record. Clinical history and treatment history of the patient is very, very important, and this should be always there in the requisition form. The lab should be made aware of these two things because clinical history and treatment history helps a lot when the results come and the interpretation of the lab results is done, and the lab has to release the report to the clinician. And the test, whatever is the examination investigation is written, that should be clearly and legibly mentioned with a proper signature of the person who is asking for the investigation. Now you can see that there was a study which was published. This study tells that the most of the biggest chunk is basically of clinical diagnosis, where you can see in the blue chunk, it is basically the clinical diagnosis was missed. The test requisition form or the examination requisition form didn't have the clinical diagnosis mentioned on that. So this was information which was not there, which is required by the lab all the time. So this information should always be provided because this helps in proper release of the report. Now coming to order of the draw. Order of the draw is very, very important. When which sample has to be collected first. Like here it is on the blood culture bottles are to be collected, and blood culture is supposed to be collected. Proper aseptic precautions, concentrate in and out with alternate procedure of either 2% chlorohexidine solution or with isopropyl alcohol. And then comes the citrate tube where coagulation test is done, then red tube, that is the pain tube, where biochemical examination basically or physiological examinations are to be done, and followed by lavender and gray and other tubes. This order of draw knowledge should always be there in sample collection facility, and all the staff of the phlebotomy should be aware of these things. Now coming to tourniqueting. Tourniqueting should not be done for more than 1 minute. Because if tourniqueting is done more than 1 minute, then hemoconcentration will lead to certain fluctuation of parameters in the test results. Patient who is under stress or coming rushing to the lab and not giving time in the lab and just want the sample to be collected should not be should be made to relax, and then the sample must be collected because some certain factors are raised by factor 8 and these things will definitely interfere in the test results. So here also you can see K3 EDG should not be used because International Council of Standardization in Hematology recommends the use of K2 EDG because K3 EDG is going to decrease the cell size and MCV will be decreased to 1 to 2%. You can see this example of sample errors on the round samples. You can see the overfilled tube. You can see the first diagram where the sample is collected beyond the mark. It's overfilled tube. The ratio required is 1:9. So this ratio is not met, and microclot formation may take and be split shortening of the APTT result for the APTT test is asked. In the second diagram, you can see underfilled sample, and the excess sodium citrate is left in the bottle in the blood collected sample, and this comes in the plasma and consumes the calcium from the reagents, and thus prolongation of PT and APTT takes place. You can see here, although the ratio is maintained 1:9 and sample is properly collected, but if it is in contact with heparin, then it is going to prolong the APTT. So contact in heparin for hospitalized patient, for ICU patient, and who are having central line or cannulas inside them, and where the clot is there, which is to be dissolved by using heparin, So in that cases, you have to always be careful that heparin contamination should not come in coagulation sample because they are going to give erroneous results of BTT. Prolongation will be there. At the same time, delayed. If the sample is not transported to the laboratory within stipulated time, then delayed sample will lead to factor degradation. Maybe after 4 hours, the factor will start degrading at room temperature, and they are going to affect in the end result of prolongation of aging ability to take place. These are the things, these are the samples where like hemolysis, icterus, and lipemia may interfere in many biochemistry parameters, and every fit literature of the different biochemistry parameters give their sensitivity index for these hemolysis, icterus, and lipemia, and the lab has to accordingly see whether these samples are required to be processed, pre-processed before they are put for actual processing or a repeat collection is required. So you can see here the sample rejections. Basically, you can see insufficient samples and this distribution of pre-examination sample errors. So errors of insufficient samples and the incomplete requisition form and then errors in transportation. So these are the major things, and clotted samples definitely. These things were observed more when the sample collection facility analysis was done, for the sample rejected samples. Now, in the traditional way of collection of blood by using syringe, needle, or scalp pen, always we have to use 22 or 21 gauge needles. Lower gauge needles like 23 or 24 is used for blood sample collection than hemolysis. Also, when you are delivering the sample from the vacuum chamber, you always have to remove the needle and before to deliver the vacuum chamber of the tube because of the pressure. If the needle is not removed, then it is going to rupture the RBCs and lead to hemolysis. Vigorous shaking or vigorous mixing should not be done because it is going to lead to foaming and hemolysis. Now, other findings like in the list of directory of services, the laboratory sample collection facility must always have a list of directory of services, the list of services the lab is providing. So you can see in the accredited lab, the list of services was not there. None of the lab had their directory of services, and also the sample collection manual which describes everything about sample collection, patient preparation, how to collect the sample, how to prepare the patient, how to packing, level, level packaging, and everything that is mentioned. That manual was not there in the non-accredited lab. So this was a significant finding, and the other findings were not significant. Then other findings like vaccination, which is very important for the healthcare worker, also in sample collection facility. Whenever there is an appointment or recruitment of the any healthcare worker who's dealing with patient or sample, the 016 of vaccination of hepatitis should always be done. But in non-accredited lab, none of the staff was found to be vaccinated with this hepatitis B vaccine. So this is a very alarming thing in my finding. Then, as far as health and safety is concerned, gloves and lab coat and mask and everything, all these things are provided even by the non-accredited lab staff on 93% for meeting the criteria. So, outcomes of the study, further the criteria like transportation and pathology of the specimens, you can see non-accredited lab basically did not meet the criteria of transportation of the samples in a proper way as per the requirement of the checklist. Then you can see this is one of the figure. This is one of the video which I can play here for how to pack the sample. See, the sample was collected and then the absorbent cotton. Now it is the person who is placing the absorbent cotton over here. So this is triple level packing. This is the first level of packing where the sample is collected. It is kept in the tray, which will be transported, and now the absorbent cotton is placed over there. Now this person is going to do what? He is going to put some more absorbent cotton, and definitely then all this whole setup is going to go in a zipper plastic bag with a biohazard sign. So this is the first level of packing, and this is what he is doing now. He is trying to put the bag looks a little smaller, but I think he will be able to do it. So he is doing his best, and you can see he is trying to put the samples properly in the Ziploc bag. And the Ziploc bag, if you can see, it is having a biohazard sign on that. So this is called as first level of packing, triple level of packing, and tri level of packing. Now, after he does this, after the packing is done properly, what he will do is he is going to put the whole sample with Ziploc envelope and is trying to add some more cotton because it feels that if there is some like maybe some blunt hit to the sample, if the sample leaks, then it will not come outside. It will be absorbed by the cotton itself. So he's putting some more cotton. He's trying to pack it properly, and now he's going to put everything in that bag, the black bag which he has kept over there. So this is what he has done over here now. Now you can see this is done. So this is the thing. Now he's going to put some frozen packs, ice cold packs to maintain the temperature. The temperature if it's less, it is going to restore the integrity of the samples. So he's doing that now. So he's trying to put the frozen packs to maintain the temperature. Now this is what he has done. So this is second level of packing, and finally the whole thing will be put in a proper transport bag, which might be a sturdy transport bag. So this is trial level of packing. You can see the non-accredited labs, they are not meeting this criteria, whereas accredited labs, most of the people were met the criteria, most of the labs have met the criteria. So as far as feedback is concerned, because the labs are getting patients at the sample collection facility, and patient doesn't know where the sample is going and where the sample is getting processed. So in the sample collection facility, and the feedback boxes should be there, and the feedback form should be kept, and suggestion form should be kept for the patient. You can see in the accredited lab this criteria were met. As far as literacy of the feedback is concerned, review and resolving the problems and the feedback, 71% of accredited met the criteria, whereas non-accredited, there was no provision for taking the feedbacks or complaints of the patient, and there is no, obviously, if there is no feedback, there is no redressal also. Okay, now to conclude my study, you can see chances of errors are very significant, and quality of testing affects the patient's safety. So area of instrument at multi-level, we have seen multi-level criteria where improvements can be done. And this study basically gives an idea like the accreditation is a very important tool for bringing in quality activity in the sample collection facilities. So benefit of the study was the labs which are not doing the things properly, or they're not doing a good practice, they were informed the losses in the practice, and they agreed to it, and they started implementing it properly, and it solved the problem. So this basically the paper was published in an international journal also, and this publication was done, and I think I finished my presentation. Thank you.
I am Dr. Haidar, consultant in anesthesia and intensive care, assistant prof also in my college. I want to present this study that we make it to assess the satisfaction of the patient who are conscious during the whole operation, and this is mostly happen when we give regional anesthesia. We select the patients who perform lipo abdominoplasty under epidural anesthesia as a target for our study. We collect the things that can bother the patient when he or she are in the operation theater doing the operation, and we make it as a questionnaire. As you see that there will be a video here presenting our patients while they are conscious, and we are doing the operation for them. This work has been presented by me and my colleague, Dr. Kurdu, who was also consultant and assistant prof in plastic surgery. As you know, that the patient satisfaction has been considered by medical community as an important parameter in the analysis of the administrative healthcare services. it is considered to be decisive for two reasons. First, it may be enable tracing and correcting the fault in healthcare system or impotency. Also, the second, this approach can meet patients' desires and expectations, also resolve their speculation, and consequently increase their trust and cooperation with healthcare team and their policy and practice. We exploited our relatively reasonable experience. It is too long, actually, about 15 years in this type of operation under this type of anesthesia, epidural, I mean, in performing lipo-abdominoplasty under epidural anesthesia to test the intraoperative patient subjective factors that make them or him or her satisfied or not. The aim of this study is to make firstly to make a question a valid and reliable self-reporting multi-dimensional questionnaire assessing patient satisfaction with preoperative and anesthesia care that include questions about confidence of the patient with the medical team, information that have been supplied to the patient from the medical team, professional competence as he or she assess as the services that they will give to the patient, and staff-patient relationship, the relationship between the staff, surgical staff and the patient, in addition to examining of these factors. Okay, the objective, it was to evaluate for this satisfaction point in patient conscious performed lipo-abdominoplasty under epidural anesthesia that would decrease the efficiency in this procedure. Determine also, the second objective is to determine which factor maximize satisfaction level through all phases of the perioperative period. The method that we use in this articles and the material, we include all the patients that underwent lipo-abdominoplasty under epidural anesthesia, who were conscious all over the patient. As you see that the patient is chatting with her family by the phone while we are working, so they can assess during this period the satisfaction. The exclusion was as follows: any patient reviews to enter the, of course, they have their right, and patients who had given any sedative or analgesic drugs intraoperatively, so he or she will not be fully conscious while we are doing the operation, and believable response to Google form. As you will see that we will send the questionnaire by the Google form through the social media that available for this patient 1 week after the operation, and they will respond to us through this Google form. So any unbelievable response that the patient make it all yes, all no, or they select something not reasonable, we will neglect it. Any also with the exclusion, any surgical or anesthetic complication that happen intraoperative or postoperatively, also we will omit this patient. Any patient has developed the complication, we will remove it from the assessment. The questionnaire, we make it as a cross-sectional survey using a structured and disquised questionnaire of dichotomous question. So the question will be answered by yes or no. That concern the patient's reconstruction with intraoperative period. The amount of information order to make life better. The level of, am I still online?
Yes, doctor, we can hear you.
Okay. Okay, the level of physical comfort and presence of side effects, the presence also of emotional support from the side of the surgical team, the respect of the patient values. Also, you know, as we know that in Iraq we have a lot of ethics, a lot of groups, ethnical groups that they have their beliefs, they have their values. So also we'll examine is there have their respects enough or not. This is the questionnaire. It's composed of 23 questions that will be answered by yes or no. Yes or no. It is different in target. The data collection, the questionnaire were distributed to the target patient in a period of 1 week after discharge home. Patient had to complete the question.
Doctor?
Questionnaire on their own without impression question and bad impression question. The good impression question, we will give 2 for the yes answer and 1 for the no answer. And for the bad impression, we will give 2 for the no answer and 1 for the yes answer. Then by the descriptive studies, through the frequency, some of the value would calculate to get the category of this question. Any question, all the question has its own category. Here we will see the results that these 2 questions, is it a good type of anesthesia? Did you feel secure intraoperatively? We have 103 patients regard these 2 questions. More than 75 patients of our patients mention epidural as a good option for their operation. Nevertheless, about 50 of the patients felt insecure intraoperative. Okay, the results were that long-time surgery. This is the what about long-time surgery, feeling of stress. Okay, staying in one position, feeling cold, shivering, have the medium rate of bothering the patient. Here, the medium rate of bothering the patient, that this question collects 138 to 172 points. Okay, under hyperthyroidism anesthesia. On the other hand, the rate of bothering was low. So they collect this rate 173 to 206 of almost full. Come on, like if the discussion between the member of the surgical team, the team, they were discussing medical problem in front of the patient, and in medical language, the patient cannot participate in it. And feeling anxious about the patient also, if he's feeling anxious. Instant surgical light, the light of the surgery was very annoying, but here it is of low bothering. Dizziness, feeling dizzy. Thirsty, of course, we cannot give water during the operation. Itching, nausea, vomiting, noise of the, you know, the operation theater. Almost always, if there is a complicated operation, it will be noisy. pain and dyspnea intraoperative. The third type of question, which where there are 4 in numbers, were applied right on the relationship between the surgical team and the patient. Like this, did the operation theater team deal with you with respect, or do you find the result of the surgery as you expect? The other one, did the operation theater provide enough information about the medication and their adverse effects before, and you find it as it? Should you undergo the same operation once again? Would you rather have the same anesthetic procedure? The answer was those mostly having no problem to do another operation with the same type of anesthesia. Meanwhile, less than 50 of the patient as for higher level of respection and enough information about the medication they asked about. So they were bothered by this 2 items. Although they satisfied the final result of surgery, but less than 35%, 1/3 of the patients mentioned that they found this result different from what had been described by the surgical team. Of course, you know that in the plastic field, we have a percentage of patients they will not satisfied even whatever happened. The conclusion was as this: factors that will have will cause highly dissatisfaction for the patient was noise in the operation theater, pain, coldness, of course, nausea, dizziness, ignorance by the medical team, feeling of stress, feeling of worry. So these factors, if you want to make a patient surgery under regional anesthesia and you will keep the patient fully conscious, you should decrease these as much as possible. Of factors mildly cause this dysfunction, it was dyspnea, it was painful, shivering, vomiting, itching, thirsty, lights of the theater, surgically lights, I mean, time of operation, position during the operation also. The quality of anesthesia, feeling secure, preserving patient dignity, and supplying enough information are the point that would increase the patient satisfaction here in our study. These 4 factors will increase the patient satisfaction, and it will increase the confidence in the health system. We have some deficiency in our study. It is better to be double-blind study, of course. It will be better, so somebody will assess our work. It is also better to expand the target to include more hospitals and more centers, more provinces. Okay, it is more scientific to include the complicated operations also, because this one will give a bad impression about the surgery. So we should make, if we want a general impression about the satisfaction of the patient about the health system, we should include it those also.
Good morning. My name is Purification Jordana Fernando. I'm a medical doctor. I'm a specialist in family and community medicine. I graduated in Barcelona, Spain, and I'm glad to show you a case I had in my daily practice. I'm going to share with you the screen. It's about a 39-year-old woman presented with pain in the left nipple and that worsened with breastfeeding. She had a history of gestational diabetes and normal vaginal delivery 1 month prior. She did not report any toxic habits. On examination, the left nipple showed no fissuries, signals mastitis, or skin lesions that might indicate other causes such as Candida albicans infection. The nipple opening turned whitish when the patient was anxious. She was diagnosed with Raynaud phenomenon of the nipple and was treated with nifedipine 20 milligrams per day, leading to symptom improvement. 3 months later, she consulted for evening fevers that did not respond to paracetamol and acetaminophen. She had no other symptoms. Blood tests showed stimulating hormone of thyroid of 0.0008 milliunits per liter, normal between 0.550 to 4.780 milliunits per liter. Free thyroxine to 48 picograms per milliliter, normal between 2.13 to 4.20 picograms per milliliter, and anti-thyroglobulin antibodies more than 500 international units per milliliter. Thyroxine 3 was normal. Antiperoxidase and antithyroid stimulating immunoglobulin were negative. She had no visible or palpable goiter. She was diagnosed with postpartum thyroiditis. During the follow-up, stimulating hormone thyroiditis and free thyroxine levels were rechecked after 2 months and were normal. Over the 12 months of follow-up period, the patient experiments a few episodes of Raynaud phenomenon of the nipple. The thyroid function remaining normal. We describe a case of Raynaud's disease with the nipple and postpartum thyroiditis. Raynaud syndrome is characterized by episodes of ischemia manifested by pallor, cyanosis, and redness in response to stimuli such as cold and emotional stress. Raynaud's phenomenon was first described by Maurice Raynaud in 1862. It's idiopathic, although vascular and neural mechanisms are believed to be involved. Raynaud's phenomenon of the nipple is rare and was first described in 1970. In 2004, Anderson and his colleagues described 12 causes of Raynaud's phenomenon of the nipple associated with painful breastfeeding. Raynaud's phenomenon affects approximately 20% of healthy women of childbearing age. This most commonly occurs in the fingers, although it can also be described to affect the nipples. Breast pain in Raynaud disease of the nipple is a common symptom described by gynecology specialists and a frequent cause of breastfeeding discontinuation. Raynaud's phenomenon of the nipple is associated with painful breastfeeding and through 2 or 3 phases of color change that worsen with cold. The nipple color may change from pale to blue and then to red, triphasic, or from pale to red, biphasic. It may be associated with the consumption of tobacco, alcohol, coffee, and certain medications, and it can be related to migraine and other conditions linked to vasospasm. There is no specific treatment, but symptoms can be managed by identifying and avoiding the triggers. Nifedipine is useful for nipple vasospasm. It is unknown whether it tends to persist or resolve over time. In our case, it occasionally recurred during follow-up. Postpartum thyroiditis is an autoimmune disease that occurs primarily within the first year after childbirth and is estimated to affect the 4.9% of the general population. It is characterized by a hyperthyroid phase between the first and third month postpartum, which may be followed by an hypothyroid phase between the 3rd and 8th month postpartum. The hyperthyroid phase often goes unnoticed because its effects are minimal or asymptomatic, and it tends to resolve spontaneously. Among women who develop hyperthyroidism, 25–30% experience permanent hypothyroidism during the hypothyroid phase. To make the diagnosis, determining stimulated hormone of thyroid levels is sufficient. Women with a history of postpartum thyroiditis should be monitored in subsequent pregnancies because there is a recurrence rate of approximately 70%. Anti-thyroid medication is not indicated in case of postpartum thyroiditis associated with hyperthyroidism because it results from destructive thyroiditis. Beta blockers can alleviate symptoms and should be discontinued after 2 months. There have been cases of Raynaud phenomena associated with hypothyroidism. The mechanism of action has been shown to involve hypersensitivity to alpha-adrenergic receptors and an exaggerated response to vasoconstrictive action of catecholamines. In previous studies, cases of hyperthyroidism and Raynaud phenomenon have been associated with connective tissue disease such as diffuse or localized scleroderma, CREST syndrome, Sjogren syndrome, or mixed connective tissue disease. One case was associated with lymphocytic thyroiditis and another with Graves' disease. However, we have not found studies linking Raynaud's phenomenon to hyperthyroidism in isolation. Our patient presents with Raynaud phenomenon of the nipple, followed by postpartum thyroiditis, the latter being an autoimmune thyroid disorder. This may have been caused by mechanisms different from those previously cited. Unlike the cases in the literature, our patient presents our only thyroid postpartum and autoimmune disease, as an autoimmune disease. Autoimmunity can be triggered by genetic predisposition, influenced by the environment by alteration in physiological mechanisms, leading to the development of autoimmune disease due to exogenous causes like molecular mimicry or antigenic hyperstimulation, as Strater et al. Describes in one publication. It is suspected that other factors besides the genetic ones must exist, because this has been observed in twins, but not in other brothers. Hormonal factors may influence it because all causes associating Raynaud phenomenon of the nipple with autoimmune disease have been described in women. This could also be due to the fact that women are more likely to develop breast pathology. As a conclusion of our case, when a patient presents with Raynaud phenomenon of the nipple, thyroid disease should be kept in mind. That's all I want to share with you. If you have any question, please be free to send me an mail to this address, pjona@bcn.ics@gencat.cat. Thank you very much for your attention.
Good day and green greetings from the Philippine College of Physicians Committee on Climate Change, Environment and Health. I am Dr. Paula Santamaria, a prime mover of the committee. Thank you so much for this honor to share the stage here in Dubai with all of you. In behalf of the Philippine College of Physicians, I salute the organizers of this successful third international conference on primary care and public health care. Indeed, transforming public health, innovative approaches in primary care and preventative medicine couldn't be a more perfect venue to spotlight on our role as doctors for the people and for our all-time biggest client, Mother Earth. I was a victim responder of the November 8, 2013 Category 5 Super Typhoon Yolanda, with gusty winds of 315 kilometers per hour for 6 hours and storm surges more than 25 feet high. In the aftermath, a lonely howl of a dog pierced the still air, its soulful dirge echoed by a mournful pack. Nearby, a rooster crowed bravely, "All is well." Yet, my Tacloban, once vibrant, momentarily erased from the map, resurfaced wasted, mangled, misshapen. Her people, 7,000 souls less, some babies snatched from their mothers by the ruthless seas. And oh, what did they call us? The living zombies. Stripped of everything except the will to rise, we stood defiant, resilient, thriving beyond the cold, hunger, anarchy, broken promises, and a severed healthcare link. The truth long denied now crashes through the silence. Climate change flaunts our doorsteps. We cannot choose to look away. Super Typhoon Yolanda was my climate changer, and these are my lessons. Dirty coal kicked off industrialization in the 1800s and sparked the Great Acceleration. Burning fossil fuels like coal, petroleum or rock oil, and natural gases powered mass production, illuminated our homes and streets, quenched our need for speed and precision, connectivity, fashion, our daily activities. But on the horizon rose a dark smoke, the smog, and released greenhouse gases like carbon dioxide, nitrous oxide, and methane. These smog and greenhouse gases cause significant environmental degradation and health issues. The majority of greenhouse gases is carbon dioxide. That is why the total output of greenhouse gases is called a carbon footprint. These gases in the air can trap heat to produce a greenhouse effect since 1824. What is a greenhouse effect? A greenhouse effect is a natural phenomenon and saves the earth from freezing. The atmosphere allows sunlight to pass through to the earth's surface. As earth's surface is heated by sunlight, it radiates a part of this energy back towards space as infrared radiation. This radiation, unlike visible light, tends to be absorbed by greenhouse gases in the atmosphere, raising now its temperature. The heated atmosphere in the turn radiates infrared radiation back towards the Earth's surface. However, when greenhouse gases occupy the atmosphere, the heat absorbed is more intense. This increases the Earth's temperature, called global warming. Carbon dioxide levels now at 421 parts per million, the highest in 4 million years, create stronger greenhouse effect which intensify heat waves. Heat indices scaling dangerous levels of 45 degrees Celsius was reported in the Philippines just this March of 2025. Heat is mostly absorbed by the oceans, and the amount of energy accumulating in the oceans is equivalent to detonating 5 Hiroshima atomic bombs per second for 25 years. Climate change encompasses global warming and refers to the shift in long-term weather patterns over decades. Climate change causes increasing temperatures, extreme weather disturbances, rising sea levels, and increased carbon dioxide levels. Altogether, this climate impact compromise environmental integrity, exacerbate nutrition and water safety, the global economy, and above all, our health and well-being. Climate change exacerbates air pollution that kills 7 million premature lives every year, and these are from cardiovascular diseases, exacerbation of respiratory diseases, cancers, and many more systemic and reproductive impacts. This is our climate penalty as construed by the World Meteorological Organization. If the world can cooperate to keep to the 1.5 degrees Celsius threshold and pursue efforts to keep warming within the safer limit of 1.5 degrees Celsius, there will be more biodiversity loss. The Intergovernmental Panel on Climate Change also warned of a global temperature increase of 2.6 degrees to 4.8 degrees Celsius by the end of the century, making sustainability the most critical agenda in the Anthropocene. Climate change impacts will increase demand for healthcare services. But as we deliver our service to promote health, protect population health, and prevent diseases and injury, the healthcare sector also produces greenhouse gases, a bidirectional movement as described by Professor Jeffrey Braithwaite. We produce greenhouse gases in 3 ways. Scope 1 refers to greenhouse gas emissions emitted directly from healthcare facilities. These are the on-site fuel combustion from the medical center vehicles, ambulances, broilers, and certain anesthetic gas leaks. Scope 2 covers the indirect greenhouse gas from electricity purchased by the facility. Scope 3 comprises all optional indirect greenhouse gas emissions. We gain the carbon footprint of supplies and equipment we purchased, the transport of the medical staff and employees to and from work, air travel, the food we eat, and healthcare waste from the time it is generated to its final disposal. Clearly, we can influence to decarbonize not only our internal operations, but also pressure our supply chain to adhere to the standards of green operations. Overall, the healthcare sector worldwide contribute 4 to 5% greenhouse gases, which is 2 gigatons of carbon dioxide, equivalent to the annual greenhouse gas emissions from 514 coal-fired power plants. Fact is, if we were a country, we would have been the 5th largest emitter of greenhouse gases next to China, USA, India, and Russia. Environmental health is a branch of public health concerned with all aspects of the natural and built environment. As of 2016, WHO states that environmental health is a fundamental component of a comprehensive public health system. Environmental health works to advance policies and programs to reduce diseases and other environmental exposures to air, water, soil, and food, to protect residents and provide communities with healthier environments. According to the World Health Organization, as of 2020, 24% of global deaths are linked to the environment, which is roughly 13.7 million deaths per annum. How then can we as physicians be true to our mission in both words and in our actions? How do we tell the story that climate change and environmental degradation is killing us prematurely? How can we be the trailblazers in our community to engage the masses to strengthen climate actions? How do we lift our trusted voices to advocate and enact policies? Where can we integrate our health data with other systems to drive a climate action? How do we heal and harm no one, especially Mother Earth, at the same time? As first responders in healthcare, the internists of the Philippine College of Physicians embraced a new role. I am Doctor of Earth, closing the gap between people and planetary health. The Philippine College of Physicians is a world-class organization of physicians that sets the highest standards and ethical ideals in the practice of internal medicine and provides dynamic leadership in the promotion of health and quality of life, in the management of disease, and in the formulation of relevant health policies. Sixth in the mission is to be responsive to the changing environment. The college created the Climate Change Committee in 2014, resting on a framework that envisioned a balanced and thriving ecosystem resulting in a resilient Philippines against climate change. The battle cry: to teach, to plant, to protect. The strategies were to amplify campaigns for climate and health awareness and capacity building and knowledge exposition, information, education, and communication, and research and training. Tools to mitigate climate change were policy formulation and program implementation, resource augmentation and aid on legislation, and multi-sector partnership. In 2021, the committee was amended to be the Committee on Climate Change, Environment, and Health, powered by the vision, "Together, we lead for people and planetary health. We pursue again to teach, to plant, and to protect." We reach out to heal, harm no one, foremost, eliminate and mitigate environmental impact, act on threats and pandemics, like the health sector with aggressive human resource synergies. For specific actions, we send peace, prime movers to raise awareness and advocate sustainable and healthy solutions to healthcare practices harmful to the people and Mother Earth. Engage other medical specialties and stakeholders to create synergistic actions for environmental justice. anchor in policy makings and best practices governing human and planetary health at a local and global scale by providing expert health information and guidance. And I believe our presence in this conference now is a testament to these actions. Capacity building of human resource through training and research, and to establish biodiversity protection programs. We are the prime movers, a 20-man committee and stronger with 14,000 internists spread out in 30 PCP chapters nationwide, 17 attached component and affiliate organizations, and 148 accredited training organizations in our wings. The organization is aligned in a strategic framework with the PCP Board of Trustees at the top, the Climate Committee in the middle, and the base shared by the PCP chapters, attached component and affiliate organizations, and accredited training programs. The PCP Board of Trustees is the heart of management activities and strategic planning, assuring that we carry on the goal of the PCP to be responsive to the changing environment. At the bottom of the pyramid is the operational control, ensuring that we achieve our daily tasks efficiently and effectively to be stewards of our people and Mother Earth. Management control is at the middle of the pyramid, occupied by the Committee on Climate Change, Environment and Health to supervise activities and allocate resources of PCP efficiently and effectively. This framework allows a top-down mandate for a unified climate action and also a bottoms-up operation to allow PCP chapters to act on environmental threats unique to their locality, but always in strategic collaboration with PCP and the Committee on Climate Change, Environment and Health. The 5-year strategic planning started with owning to the problem and embracing the new brand, I am Doctor of Earth. On 2022, we acknowledge the way forward to restore people's health is to restore Earth first. On 2023, we moved to clean up our act with SWEET, sustainable work towards equitable environmental protection. In the May 2023 Congress, no PET bottles were allowed in the Congress. It was, reassuring to see physicians clutching their hydration flask, saving PCP millions of pesos worth of plastic bottled water, and ultimately reducing our solid waste. On 2024, we were I Am Influence, inspiring, fostering leadership, and sharing unique practices to nurture our communities and environment. On 2025, we should be ready to scale the heights, aiming higher and higher to reduce our carbon footprint. Let's pause to calibrate, recalibrate, and strengthen our best practices. On 2026, we should live a life of green, and 2027 outlive, meaning to survive or to last longer, challenging us to go beyond the evidence-based medicine to the medicine-informed medicine. Utopian? But I have great faith we can achieve as we have gained momentum past our climate inertia. And we will continue to win one doctor at a time. We are strong because the committee is founded on the spirit of volunteerism. Prime movers are passionate, committed, and contribute diverse perspectives to the problem. By inspiring our PCP chapters, we were able to build the I Am Doctor of Earth nationwide and expand it to our communities. Sustainability is a given. The PCP has a strong political will and might with members who are strategically aligned. A budget is allocated for the committee projects every year, and recognition is awarded to all PCP chapters for their involvement in the November 8th Day of Rising Green event, which covers climate campaigns, tree growing activities, and biodiversity conservation projects. The PCP has a roster of doctors who can be expert witnesses on climate and health. Social media presence through the I Am Doctor of Earth wall allows broader outreach and real-time engagement. The PCP Committee on Climate Change, Environment and Health has a strong technical support for scientific and policy backing from healthcare partners. Today is our debut in the international arena, and we hope to establish linkages soon. I'm sure we can learn a lot from other climate organizations. We would like to advocate for health-centered solutions for a sustainable medicine. Weaknesses: time constraints. Busy professional schedules restrict time for volunteerism. Climate inertia. How do we inspire other members to take a climate action? This may be due to a lack of unified vision and buy-in, and some members may have diverse perspectives and different engagement level. Leadership struggles, inadequate training, and lack of specific skills. We could use some help there. Limited staffing has the potential to exhaust the core members. Opportunities: amplified climate and health education to bring health perspectives into climate policy negotiations. Advocate for health protective climate policy reforms. Integrate research and data to translate science into action. Greening the healthcare. More community engagement. Global health and climate justice. Threats: targeted harassments by authorities and the threat of political and public backlash. And that climate thingy, to be received as irrelevant by climate deniers and different colleagues and community. Emotional toll, especially for members who are in the front line of climate disasters and pandemics. Financial support may dwindle with the unstable economy. Disinformation, misinformation, this should always be supplanted and verified by a fact check. Future directions. The PCP will not only be responsive but proactive to the changing environment. We have to calculate the internet's carbon footprint with a carbon calculator. For how else can we treat well if we cannot measure the problem? We have to improve our climate discourses, integrate climate change and health in the curriculum of residents in training in internal medicine, and to complete the compendium of climate and health as a resource for the PCP and stakeholders. For it is by knowing the climate story and being able to narrate it to our patients that we can all fully understand the climate crisis. Then we are able to mitigate with actions to reduce greenhouse gas emissions or remove this from the environment. We can all adjust to the effects of climate change as we adopt infrastructural, behavioral, and nature-based solutions and become resilient people from climate hazards. Only then can we fulfill our mission to be Doctors of Earth. For it is only when we put a premium on the health of Mother Earth alongside that of people's health can we say we are true to our Hippocratic oath. First, do no harm. Thank you so much for your kind attention, and a heartfelt thank you to the Philippine College of Physicians through the stellar leadership of President Imelda Mateo, to the prime movers of the Committee on Climate Change, Environment and Health, and this presentation is lovingly dedicated to Sis Marisonia Belentan. To people and planetary health, cheers!
Bueno, vamos a conversar hoy sobre la exposición que le tengo preparada sobre los efectos o la relación que existe entre la retinopatía hipertensiva y la hipertrofia ventricular izquierda en pacientes hipertensos. Yo soy Luis Dorta, médico internista y epidemiólogo, egresado de la Universidad de Carabobo y posgrado en el Hospital Central de Maracay. Es importante realizar este estudio porque hay que darle herramientas a los médicos generales, esa es mi conclusión, en atención primaria en salud, para que ellos aprendan a identificar los factores de riesgo y hacer un examen de fondo de ojo, que significa no invasivo y de bajo costo, tanto lo que es el fondo de ojo como las maniobras semiológicas para detectar si hay desplazamiento del ápex en el ventrículo izquierdo y luego posterior otro examen que no es invasivo y no es tan costoso como el ecocardiograma. Fíjate, la hipertrofia ventricular izquierda y la retinopatía hipertensiva son comorbilidades presentes en pacientes como resultado del proceso, es un proceso degenerativo asociado a la hipertensión arterial, y cada uno que se estudia de forma aislada, pero hay que verlo como una entidad, ya que hay una conexión sistémica en estos sistemas. La siguiente. En este estudio fue realizado con estudiantes del último año de la carrera de medicina en la Universidad de Carabobo, Venezuela, en el 2019. Este grupo de estudiantes del último año de la carrera, como les dije, en el Hospital Central de Maracay, que es su hospital universitario, se planteó como un gran objetivo evidenciar la relación que existía entre la retinopatía hipertensiva y su efecto en la hipertrofia ventricular izquierda. La siguiente. Este estudio fue un estudio clínico epidemiológico de tipo analítico observacional de corte transversal, el cual incluyó a 40 pacientes hipertensos que acudieron a la consulta de cardiología y oftalmología de este mismo Hospital Central de Maracay. La siguiente. La edad promedio de estos pacientes fue 67 años. Un promedio del sexo femenino un 70% y un masculino un 30%. En nuestra realidad en Latinoamérica, la motivación de ir al médico es más preferente en el sexo femenino que el masculino. En la ocupación de estos pacientes, el 46% eran amas de casa, un 16% obreros, y entre profesionales y técnicos un 38%. La retinopatía hipertensiva grado 2 corresponde a un 68% de los casos. Se observa la retinopatía hipertensiva grado 2 y la hipertrofia ventricular concéntrica, excéntrica y concéntrica entre un 24 y un 32%. El 70% de los pacientes en estudio no estaban bien controlados, a pesar de recibir tratamiento. Y aquí me quiero detener un poquito porque es un hecho natural y ya comprobado que inclusive a nivel de países desarrollados, a pesar de tener un diagnóstico y una medicación, el apego o el cumplimiento del tratamiento es bajo. Por ejemplo, en nuestra realidad aquí en Venezuela, en el estado Carabobo, solamente un 25, un 30%, según el año pasado las estadísticas, cumplían tratamiento, a pesar de saber que eran hipertensos, a pesar de que tenían el medicamento, no lo cumplían satisfactoriamente. Múltiples factores que eran polidosis, tenían una no apego a ese tratamiento que, por supuesto, va a traer sus consecuencias más adelante porque los órganos blancos, los órganos diana de esta patología van a sufrir el embate de esta complicación. La media del diagnóstico de hipertensión arterial con la aparición de cambios geométricos en la parte cardíaca correspondió en un promedio de 13 años. O sea que si usted detecta un paciente y no está bien controlado, a los 13 años ya tiene hipertrofia ventricular izquierda y ya tiene daño a nivel de la retina. Esto es importante desde el punto de vista de la atención primaria en salud. Es fundamental como primer nivel de atención, o los médicos de choque que lo llamamos nosotros aquí, darle las herramientas suficientes para que logren detectar, prevenir y abordar los factores de riesgo, tanto sobre todo los modificables, que serían el exceso de sal, el tabaco, el cigarrillo, el sedentarismo, la dislipidemia, que esto junto con estos dos factores anteriormente asociados a la hipertensión arterial nos va a producir una carga económica en los hospitales. Se nos van a complicar los pacientes, eso trae como consecuencia a pacientes con accidentes cerebrovasculares o enfermedad cerebrovascular, tanto isquémica como hemorrágica, donde quedan secuelas, se afecta la calidad de vida de estos pacientes. Son pacientes que van rutinariamente a control de hospital. Igual sucede también con los pacientes con insuficiencia cardíaca, producto de la no control de la hipertensión arterial. Son múltiples veces que acuden a los hospitales y esto incrementa los gastos y baja la calidad de vida, o a la inversa, baja la calidad de vida y tiene un impacto económico. Entonces, la medida del tiempo de la hipertensión arterial de aparición de la retinopatía fue 15 años. O sea, que si usted logra convencer a los pacientes y tener una buena relación médico-paciente con fármacos adecuados de larga duración o combinación de los mismos, pudiéramos obtener un resultado mucho mejor en el impacto del control de la retinopatía hipertensiva con la hipertrofia ventricular izquierda. Estas complicaciones pueden ser producto de diversos factores. Se hizo un trabajo, como les mencioné anteriormente, hubo un mal control de la hipertensión por parte del médico, no hubo una relación médico-paciente, no se le informó, eso fue lo que arrojó el estudio, por el propio paciente, un estilo de vida inadecuado, con hábitos de salud inadecuados, malos hábitos psicobiológicos, entre otros, los cuales debemos identificar cuáles son esos factores modificables y no modificables para intervenir y lograr prevenir y disminuir el impacto de esta enfermedad. La siguiente. Como gran conclusión de este trabajo que se hizo, podemos decir que los pacientes con hipertensión arterial se enfrentan a una enfermedad crónica que trae consigo múltiples complicaciones, entre ellas el daño retiniano, la alteración geométrica cardíaca, que tiene un impacto en su calidad de vida y sus expectativas de vida, y como le agregué también, la carga económica de estos pacientes. Por eso que es fundamental, a mi manera de ver, estoy convencido de ello, que hay que formar desde los primeros años de la carrera en este problema de hipertensión. Y yo le agregaría también la diabetes, que entre esos dos factores nos están dando la mayor mortalidad mundial, nacional y regional. Tenemos que hacer un esfuerzo para que de la perspectiva de la atención primaria en salud se aborden estos elementos de una forma sistemática y con los exámenes que no requieren un alto costo, como un fondo de ojo y un ecocardiograma. Y siempre utilizando la técnica de la semiología clínica, que tiene su vigencia actualmente en la realización de una buena historia clínica para identificar y tratar a estos pacientes. Bueno, muchísimas gracias por su atención.
Hello, grateful for this academic space. I will talk about solidarity, value or anti-value in the management of hematological, oncological patients, bioethical analysis of a case. Since my years of training as a physician, I noticed how companionships and solidarity were sometimes used to cover up faults or errors during a patient's care process. However, I also saw the potential for improvement. In this sense, already as a specialist and during my training as a doctoral student, I had the opportunity to show in my investigation the relevance of understanding how solidarity, among other human factors involved, can positively affect to outcome a patient's care. No, next slide. No avanza. Just moment. Yeah. What is solidarity as a value in the health care field? A health professional is expected to show compassion and solidarity with others, a sensitive approach, eloquence when communicating, humility and honesty in the process, and empathy to achieve an ideal relationship with the patient, family, and colleagues, especially when caring for patients with hematological oncological diseases. What about its impact on medical care? For the healthcare personnel, the established code of ethics and deontology is a guiding principle. However, it's important to know that not all professions in the health field have this kind of regulation. In this case, the individual's value system becomes crucial. It's the personal ethic that guide the professional's action. Solidarity, a key value, highlights the social conscience of the professional to identify and attend to the needs of the sector that require their services. Solidarity has the ethical objective of watching over and protecting those human values that are fundamental in the life of an individual, such as dignity, freedom, health, culture, and work. Now, when does it become an anti-value? For example, individuals who discern the definition of solidarity as an ethical value often consider that solidarity is not to denounce a colleague due to either incompetence or moral failure. This misinterpretation, when placed above the fundamental ethical principles of beneficence and non-maleficence, can perpetuate erroneous behaviors. First, let's consider solidarity as a value in the health personnel. Implies empathy and support among colleagues, humanize patient care, and teamwork and collaboration. However, solidarity as an anti-value is shown as a lack of support among health professionals, individualism, unfair competition, and a negative impact on the well-being of patients, such a case in which it affects the quality of care. This is why I raise the dilemma of appreciating solidarity as an aspect of each individual's character, which, depending on their value system, can become a value or an anti-value according to the result. For this, I will present a case for bioethical analysis. Purpose of this investigation to analyze the bioethical aspect of the healthcare personnel about solidarity as a value or anti-value in the care of a hematological patient hospitalized in the internal medicine service of a level 4 hospital in Valencia, Venezuela in 2019. Whose specific data will be kept in discretion by request of the relative to their right to postmortem secrecy. This research is based on confronting the perspective of the term solidarity from the intervening factors under the complex paradigm, and it will be developed in two moments. The first moment is observational descriptive and allows showing the context of reality itself to analyze it from the bioethics perspective. The second moment is carried out under the qualitative phenomenological hermeneutic approach, in which in epoche it's proposed to understand each subject of a study using techniques of open interviews guided by the researcher. The ontological assumption is to show the determining value of the ethical and moral training of the health personnel in charge of these patients to overcome the complication derived from the ethical dilemmas present in the disease or from the treatment itself, and to understand how solidarity can affect the approach of all the human factors involved in the patient's care. Research suggests medical personnel assigned to care for a patient, techniques and instruments for data collection. Information was obtained and recorded in history cards through an open interview guide by the researcher to code categorical units for healthcare personnel. The integration of multiple perspectives and expert triangulation were the criteria for excellence. Brief description of the clinical case. The patient is a 63 years old male from a urban area, retired electrician with a history of uncontrolled hypertensive arterial disease, who present 15 days with fever, dizziness, weakness, and pain in the lower limbs that doesn't subside with AINES, concomitant and spontaneous bruising, psychosocial conditions, live alone, receive retirement pension, family members, a son who visit him eventually, and niece who live a few minutes away. Psychosocial habits, denies smoking, having a sexual partner, and illicit drug use, confirms alcohol intake on weekends. The patient was taken to the emergency room of the urban ambulatory type 2 in his town, where he underwent a complete hematology, glucose, creatine, urea, and urine examination. Results show alterations, as shown in this slide, motivating his transfer to the level 4 hospital center that night. The patient was admitted to the reverse isolation room in the hematology service hospitalization to perform a bone marrow aspirate and biopsy, and start chemotherapy protocol according to the results. In addition, the protocol for requesting antineoplastic drugs from Social Security explains to the family members to obtain drugs for chemotherapy. He needs to perform special paraclinical studies, which include requesting serology for infection diseases. In this case, the results show that patient is HIV reactive. Diagnosis impressions: acute myeloid leukemia, retroviral HIV diseases, and uncontrolled hypertensive arterial diseases. The infections, diseases, and hematology services are notified, and the family members were informed, who request the diagnosis of HIV retroviral disease be withheld from the patient. 72 hours after starting chemotherapy drug treatment, The nursing staff of the night shift warned the relative that the antineoplastic drug ARAISC as Raynaud. With 4 days of treatment already protocolized by the hematology service, authorized and dispatched by the corresponding Social Security pharmacy, and previously administered without incident during the 2 previous shifts. Closing of the clinical case, the patient received an overdose of ARAC due on to an erroneous interpretation by the nursing staff on duty on day 3 of chemotherapy. He died 17 days after day 0 of the 7x3 chemotherapy protocol due to intrapharengeal hemorrhage in the context of severe thrombocytopenia and hypertensive emergency. The first bioethical situation arises, constituting a dilemma for the treating physician between 2 fundamental principles: the patient's right to information and quality of life. It is analyzed using Smith's holistic method and the protocol for presentation to the healthcare ethics committees. In the first dilemma, the situation relates to the HIV diagnosis in which the patient's family members request solidarity in counseling the news. The solution was resolved by considering the patient's human, legal, and psychosocial factors. With improvement in interdisciplinary communication, it was decided to explain to the family members the need of informing the patient of the diagnosis, emphasizing the values of respect and honesty, thereby allowing the patients to receive treatment. In the second ethical situation, the principles of sanctity of life and no inducement to harm, including the principle of distributed justice, were violated when the family members requested a new report from the doctor to obtain the medication again. The resolution of this conflict was intended to seek the greater good in a timely manner, establish corrective measures, and prevent recurrences. In this process, the main question arises: why is there a drug deficiency? Was it administered erroneously or taken from the storage place provided for this purpose? The relevant responsibility must also be established. New therapeutic options must be designed for the patient and his prognosis analyzed, clarification, and reasoning with the family members in their current state of discomfort with this situation. And the failure of the drug must be justified to the provider institute. For the second moment, in the open interview with the health personnel who attend to the patient, a total of 6 professionals, the researchers found significant communication failures between disciplines and levels. Subjects tend to experience sadness, anger, and frustration during professional practice. In some cases, they show integrate sadness. In a specific case, their expression is loaded with violence in the sense of defense, with a defiant attitude toward team, especially when they perceive lightly or not support from their colleagues and or superiors in their professional practice. Most of the categorical units show an implicit alliance system, in a mutualism that become evident when there is a perceived threat to any team member. The sense of, if one falls, we all fall. The responsibility for the equivocal participation that generates security incident is minimized and justified by circumstantial factors from the study subject's point of view. And in consideration, while presenting this case, it was possible to observe the different implications of the solidarity applied in the first situation by the treating physician, by making the comfort of the patient and his relative rival by molding news that could cause a depressive syndrome that could complicate the patient's condition. However, in the second bioethical situation, we found significant difficulties clarifying the facts and establishing associated responsibilities. The solidarity applied in a negative sense and the mutualism among the nursing staff hindered the process by not providing adequate records of the situation, not detailing the cause of the failure of the medication. In this context, the testimony of the witness family member, the only evidence available, carried significant weight. The unavailability of the medication and the administrative silence after the fact further complicated the situation. It's imperative to clarify and establish the fundamental characteristics that distinguish and identify solidarity as an ethical and consequently bioethical principle. This is necessary due to the plurality of meaning and ideas that support two terms. Although values and anti-values coexist in the individual, anti-values must be identified, noted, and minimized. The application under a negative approach of a value should not be justified and is necessary to rechannel inclination or seek strategies in the management of healthcare personnel so as not to put the life of any patient in risk. This requires an arduous work of continuous supervision, but mainly training for a humanist approach, starting with the most basic ethical knowledge until exemplary conduct is achieved. For, as Kant said, a right action is when the ability to do good is used regardless of the consequences.